afternoon, everybody. Welcome to our presentation on access to IVF and fertility treatments. This is actually part two of our series on reproductive health, hosted by the Women in Healthcare Leadership Collaborative, or WILC, and WLALA, which is a Women Lawyers Association of Los Angeles. Today, we're going to be focusing on the legal and legislative landscape, clinical realities, coverage structures, and the evolution of fertility care. Before we get started, I do want to speak briefly on the two organizations hosting this event. The first one being WILC. This is a Shepherd collaborative dedicated to bringing together healthcare leaders to foster collaboration, professional development, and the advancement of women in healthcare. We also are pleased to partner with WLALA, or the Women Lawyers Association of Los Angeles. This is a bar association committed to advancing women in the legal profession through advocacy, mentorship, and professional development. So due to the length of our programming, we will likely not be able to take questions during the presentation, but if you do have a question, please feel free to drop it in the Q&A chat below, and we will provide a response. Also, as a note, for those attorneys who are registered in New York and who are also seeking CLE credit, please remain in the presentation until the end of the programming, because we're going to have an additional verification process, which includes completing an attorney affirmation form with a code word that will be provided at the end. Next slide, please. So now I just want to give our presenters an opportunity to introduce themselves. To start things off, my name is Aliana Gallo. I'm an associate attorney at Shepherd, and I'm also part of the Women in Healthcare Leadership Collaborative. Now I'll pass it off to Carmen, who's also part of WILC and an attorney at Shepherd.
Thanks, Aliana. Hi, everyone. Carmen Jewell. I'm special counsel at Shepherd. I am based out of our New York office, and I'm a healthcare regulatory attorney, and I'm pleased to be here with you all today.
Thank you, Carmen. How about we go to Dr. Goldstein?
I am Dr. Ellen Goldstein. I'm a double board certified OBGYN and reproductive endocrinologist. I was the founding physician of Beverly Hills Fertility, which opened in 2022 in Century City in Los Angeles. And we have really reimagined the delivery of fertility care here. We're committed to evidence-based treatment only, personalized, attentive, supportive care for all of our patients.
Perfect. How about we go over to Dr. Thomas?
I'm Dr. Samara Thomas. I am a reproductive endocrinologist as well at the Beverly Hills location. I've been in practice for the past 8 years and recently joined Dr. Goldstein after she founded this practice about 1.5 years ago.
Okay. Thank you, Dr. Thomas. And last but not least, Dr. Hackman.
Hi, I'm Dr. Sasha Hackman, also double board certified OBGYN and reproductive endocrinologist, and I recently joined Beverly Hills Fertility to help open and be the medical director for the Thousand Oaks location.
Thank you so much, and we're pleased to partner with Beverly Hills Fertility for this program. Can we go to the next slide, please? Thank you so much. So this is just a brief overview of the key topics we're going to hit today, including Trump's IVF executive order, some state legislative efforts to expand access, insurance coverage, and then the evolution of fertility care. Next slide, please. So we're going to begin with part one, which discusses the legislative developments that have shaped IVF access across the country. Carmen is going to start us off by walking us through the legal and regulatory landscape on this topic.
Thank you. As a threshold matter, and I think perhaps many of the attendees here today know this, we have to keep in mind that the legal and regulatory landscape governing IVF access in the US is not only rapidly evolving, but it is deeply fragmented. As we will discuss, there's currently no federal statute that expressly protects or restricts IVF access in the country. And the Supreme Court's decision in Dobbs versus Jackson Women's Health Org in 2022 returned reproductive health regulation to the states. So this has resulted in a patchwork of laws among the states that either protect or restrict IVF access, or in many cases to date remain silent with respect to IVF. And in the meantime, IVF continues to be a hot and ever-changing topic. So just by way of example, here's a list of some cases, not all, of relevant and recent cases that show how states are currently addressing IVF and IVF-related issues. And sometimes it's the judicial decisions that then prompt legislative action. So by way of example, starting with the LePage decision in Alabama, this has probably been the most significant recent case of with respect to IVF access. In this case, certain fertility clinic patients brought wrongful death claims under the state's Wrongful Death of a Minor Act after a hospital patient wandered into a cryogenic nursery and dropped certain frozen embryos and destroyed them. Now, the Alabama Supreme Court held that frozen embryos meet the definition of a child under Alabama's Wrongful Death of a Minor Act. The court's reasoning was that the ordinary definition of a child includes an unborn or recently born person from the time of fertilization until the age of majority, and that Alabama's Constitution further required that the court resolve any ambiguities in favor of protecting unborn life, because the state constitution declares it is the public policy of Alabama to protect the rights of the unborn child in all lawful and appropriate manners. In this case, the Alabama Supreme Court rejected the position that extending wrongful death liability to extrauterine embryos would substantially increase IVF costs and make cryogenic preservation prohibitive, stating basically that these are policy arguments. They belong before the legislature, not the courts. Based on that decision, the Alabama legislature immediately enacted emergency legislation to immunize IVF providers from civil and criminal liability for damage to or loss of an embryo. And it also the legislation also addressed damages in certain cases with respect to IVF claims. So that's, again, an example where a court made a decision and the legislature immediately reacted to it. However, even with this legislation in place in Alabama, there remain questions about what will be the long-term interaction between the LePage decision and the subsequently enacted immunity statute, particularly with respect to embryos that are already in storage. Another, again, example of a case is in Colorado, in marriage of Rooks. The case is a bit older, but in that case, the court established a multi-factor balancing test in the context of embryo disposition disputes. Factors that a court will consider include the intended use of the pre-embryos, the ability of the party that is seeking implementation to have children through other means, the party's original reasons for undergoing IVF in the first place, the burden on the party seeking to avoid genetic parenthood, any bad faith that may have been involved, and other relevant considerations that are unique to those parties. And the Rooks balancing test has been adopted. This framework has been adopted by other state courts, including in courts in Indiana and Minnesota, most notably. Again, another case in Indiana, Freed versus Freed, a couple of years ago, the court applied the Rooks balancing test in the divorce context, which was for that court a case of first impression. The court awarded the frozen embryo to the mother who had no other means of procreation. And the court held that while in vitro cryopreserved embryos are not entitled to personhood under Indiana law, embryos deserve a, quote, special respect under the law. And the court also noted that there were specific Indiana statutes that require acknowledgement that human physical life begins when the human ovum is fertilized by a human sperm, but that conceded that the definition did not necessarily apply in the IVF context per other applicable statutes. It was noted in this court that usually in embryo disposition disputes, the courts tend to rule in favor of the party wishing to avoid parenthood, and there were other cases that were cited. But in this particular circumstance, it was awarded to the mother who was seeking the parenthood. Again, Virginia, recent case, held that frozen embryos are not divisible property in the divorce context. But the court did recognize that there is a gap in Virginia law regarding how do you address human embryos in the divorce context. This is not an exhaustive list, as I mentioned. Other notable decisions include a Maryland decision, Akers versus the state, 2025 decision, where the Supreme Court of the state explicitly rejected the concept of fetal personhood, stating that Maryland recognizes a fundamental difference between a fetus and a baby, and rejected the theory that attempts to redefine a person as existing from the moment of fertilization. This opinion broadly affirmed the state's rejection of fertilization-based personhood under Maryland law. In Texas, also in 2023, the Court of Appeals held that cryopreserved embryos outside of a woman's body are not considered individuals under the Texas Penal Code's definition, which otherwise requires gestation. The court noted that even though Texas's wrongful death statute's definition of an individual includes an unborn child at every stage of gestation, from fertilization until birth, it does not encompass embryos that are not gestating, i.e. frozen embryos. So basically, this case would limit the direct application of Texas's abortion ban to IVF embryos. But technically, this issue has not been definitively addressed or resolved by the Texas Supreme Court. And just by way of reference, there is pending litigation in Utah it's been pending for a couple of months, where an anti-abortion group sued 7 fertility clinics in the state, claiming that disposal of embryos as part of the IVF process violates the state's wrongful death law. Again, to be continued on that front. But basically, there are at least 10 other states that I haven't mentioned that either have a fetal personhood law or wrongful death statute that may, depending on how broadly they're applied, encompass frozen embryos. And sometimes these cases sometimes these issues are not resolved at the court or legislative level until there is a very fact-specific dispute, whether it's an embryo disposition dispute, divorce context, or a claim for a tort such as negligence with the destruction of embryos. These decisions are very state-specific and fact-specific, such as when you consider the factors that many states have adopted from the Colorado Rooks decision. Next slide, please. And I apologize, one moment. I'm having an issue seeing the slides. Oh, okay. Sorry, Aliana, are we on slide 6?
Yes.
Thank you. Sorry, I'm having issues seeing the slides, so I'm just, okay, gonna wing it. There is currently no federal legislation that specifically protects or restricts IVF access, as I mentioned before. There have been some past proposals within the past few years that just haven't advanced, whether it's the Right to IVF Act in 2024 or the Access to Family Building Act. The Affordable Care Act, which has been in place since 2010, does not mandate IVF coverage. In some, because there is no federal IVF applicable mandate that guarantees access or insurance coverage for IVF, this is primarily determined by state law and whatever state laws apply to state-regulated insurance plans. That said, there has been recent activity at the federal level to promote IVF access. In particular, in February 2025, President Trump issued Executive Order 14/2016, which is a directional statement and a signal that the Trump administration is seeking to position itself as a protector of IVF access. It's the administration's policy to, quote, ensure reliable access to IVF treatment, which would include unnecessary statutory or regulatory burdens, and to make IVF treatment drastically more affordable. Under that executive order, there was a 90-day period for the Assistant to the President for Domestic Policy to submit a list of policy recommendations on protecting IVF access and reducing out-of-pocket and health plan costs for IVF treatment. Now, note, this is an executive order, so it does not create any particular express right or benefit that's enforceable at law. It's really more of a directive rather than a legal instrument, but it does signal that the Trump administration wants to promote the IVF access. And subsequently, in October 2025, the Departments of Labor, Health and Human Services, and the Treasury announced exploring protecting IVF access, lowering costs, and encouraging employer adoption of a full range of fertility benefits. And why this matters is because many employer healthcare plans are governed by federal law, ERISA, and not necessarily state mandates. So even if a state requires state regulated plans to have certain IVF mandates or accessibility or coverage requirements, generally those state laws do not apply to ERISA plans. So again, the agencies here are attempting to create a pathway where those healthcare plans that are governed by federal law could potentially go about promoting IVF access. Or now, notably here, again, there's guidance will be forthcoming. So it's unclear exactly what developments will come in the future, but it's definitely on many people's radar. Next slide, please. Okay. Now, many states have taken legislative action in connection with IVF access. Now, again, whether that's to restrict IVF access or to promote it. In Louisiana, for example, the state has a longstanding statutory framework for IVF embryos, which define in vitro fertilized human embryos as having certain rights by law, but also providing that they are not susceptible of ownership and that it's the intended parents that have the control and decision-making authority over the viable embryos. More recently, Louisiana removed certain requirements on provider liability, or rather limitations, limited provider liability, and also removed the married couple limitation on embryo donation. So again, piecemeal developments with respect to IVF access. In Georgia, IVF is codified as a positive right. In California, which our physician panelists today can provide more practical insight about this, California expanded its Knox-Keene Health Service Plan Act to require large insurers to cover the diagnosis and treatment of infertility and fertility services effective January 1st, 2026. The coverage has to include a maximum of 3 completed egg retrievals with unlimited embryo transfers consistent with American Society for Reproductive Medicine guidelines. The law also prohibits exclusions or restrictions on coverage for fertility medications that differ from restrictions or exclusions imposed on other types of prescription medications. So insurers can't be treating IVF medications differently than other medications. And New York mandates coverage for 3 cycles of IVF for large group health insurance plans that are regulated by the state, and also enacted a Family Court Act provision governing the agreements related to embryo disposition. Again, this is not an exhaustive list. By way of reference, Colorado has a very comprehensive affirmative IVF protection framework, which became effective in May 2025, that establishes that every individual has a right to make autonomous decisions about their reproductive health, including the right to use, destroy, or donate gametes and embryos. The statute prohibits local and state governments from interfering or restricting physician's ability to provide reproductive health care. It creates a shield law declaring it contrary to Colorado public policy to permit civil or criminal actions authorized in another state against Colorado individuals for providing fertility treatments, which, as we'll discuss further with our physician panelists, is a consideration when you have states with different laws. And the Colorado law also expressly provides that fertilized eggs, embryos, or fetuses do not have independent rights under specific state laws. Maryland has had an IVF mandate for many years, and the Supreme Court issued a decision very recently that clarified that the IVF mandate requires insurers to cover expenses that arise from IVF procedures to the same extent as other pregnancy-related procedures. So from an insurance perspective, it means same deductibles, copays, or limitations that the payer may have. And yet, consider other states, for example, Kentucky, Arkansas, states that have enacted abortion statutes with fertilization-based personhood definitions that potentially could, if applied broadly, create legal risks for IVF providers and patients seeking IVF access. Now, some of these states have not applied those definitions, to IVF embryos specifically, but that is something that may likely come across judicial decisions in those specific states. And it will then be up to the courts to determine whether or not to extend the definition to cryopreserved embryos that are outside of the body. Aliana, next slide.
Thank you so much, Carmen. So now that Carmen's walked us through the legal and administrative landscape, we're going to now turn to how this all plays out in the real world through the clinical considerations for both providers and patients. So Carmen will continue on the next slide, and then we're going to receive some input from our physicians.
One moment. Okay, thank you. Okay, are we on slide 9, Aliana? I'm having issues seeing the slide. Okay, thank you. Okay, so the primary operational risk right now is what you'd call the pause effect. So take Alabama, for instance. Following the LePage decision, many IVF service providers immediately halted providing services in order to assess the legal implications of their practices with respect to embryo storage, embryo testing, and embryo transfer. So notably, it wasn't just the physicians or the clinicians who paused their practices. It was also tissue banks and laboratories. There are, to the extent there are immunity statutes, even when implemented, such as the one in Alabama, sometimes it's unclear or as to what exactly is encompassed and falls under the scope of the immunity statute. So for example, Alabama's statute protects persons that provide, quote, services related to IVF. That could be read very broadly. Does it include, storage, transportation, or handling, or is it specific service lines? Does it include a lab which processes a sample for patients from other states? Once you start crossing state lines, now we start having more legal uncertainty about potential exposure for providers, for laboratories, for tissue banks. And it puts clinicians rather, in a really difficult spot because now they have to counsel their patients not only about their clinical options and risks, but also legal risks. And so they have the burden of potentially counseling patients as to what the current legal status of embryos are, not only in their home states, but also with respect to perhaps their employer's state of incorporation, which may govern the insurance requirements that are in place, and requirements of the state where embryos are stored, which may not even be knowledge that clinicians necessarily have all the time. Because the standard IVF services include creation of multiple embryos, many of which are stored indefinitely, donated, sometimes destroyed, sometimes used in research. And so all of these different aspects of IVF services could really complicate the legal analysis depending on where the patient and or clinician are, what payer is at issue, and what the specific options to the patient are.
Thank you so much, Carmen. So this really does illustrate the uncertainty that providers are navigating at this point due to all these legal and operational changes. Let's bring in Dr. Thomas here. In your clinical experience, how do some of these IVF protocols, specifically stimulation adjustments, cycle-to-cycle decision-making, monitoring frequency. How do you see this vary across patient populations in the context of these challenges and risks?
So we have patients coming in, individuals or couples that are seeking care for various reasons. Some patients are coming in, like, for instance, the LGBTQ plus population that requires coordination amongst various different divisions. So they may be accessing third-party care, third-party services, which would involve egg donation, sperm donation, as well as surrogacy. And so you're coordinating multiple cycles at once to help with the family building, and as well as monitoring and in terms of ultrasound monitoring, coordination of surgery, and transfer amongst different population groups at one time. And so the LGBTQ plus population involves various aspects of coordination amongst the different arms. When we think of patients with PMOS, which was formerly known as PCOS, patients with low ovarian reserve, that involves frequent cycle monitoring. So patients are coming in 2 to 3 times a week for ultrasounds, blood work, and then we're making immediate decisions based off the ultrasound findings and blood work. So the operational constraints that are impacted by that is we need ultrasonographers, various nursing staff support to assist with those phone calls, follow up the blood work, whether your blood work is done in-house, depending on the capacity of that clinic, or whether you have to send blood to an outside laboratory and then provide those results to the patient. So there's a frequent monitoring, ultrasounds, and blood work as well, and then surgical coordination for all these patients. So that's nursing staff that's needed in anesthesia services as well. So depending on the patient population, their indication for treatment, the operational constraints can limit access to care for these patients.
Thank you so much for that, Dr. Thomas. Now that does relate to our next slide as well, which has another layer of complexity added to this, which has to deal with patients having to cross state lines to receive this type of care. So let's hand it back to Carmen.
Well, right. So it comes down to the patient's needs, the patient's clinical condition, as Dr. Thomas just elaborated for us, and add then the complication of where is the patient, what applicable payer requirements, if any, does the clinician and the patient apply to the clinician or the patient, and this requires reproductive health care and fertility care providers to really build workflows that address those patient needs and those the variety of those nuances based on insurance and location. Just by way of reference, 22 states have some sort of fertility insurance requirement, but coverage drastically varies by state. So for example, and even within a state, a large portion of the population may be left out. If you consider, for example, just some statistics, in California, most of the state's insured population is left out because, again, if you have employer self-funded health insurance plans, those are regulated by federal law, which again, there's not one that's directly on point. So regardless of whether the state has a state insurance law mandate, it may not apply to a large swath of the population. 30% of state-based reproductive age women in Massachusetts, were beneficiaries of the state's infertility insurance mandate. Again, not the majority of the potential candidates who would want to seek IVF access. And this is a patchwork reality. It means that the result is that patients cross state lines. Gets further complicated when employers are multi-state. And again, clinicians and clinics have to then accommodate workflows for all of these different patient situations and applicable benefit arrangements. Next slide. And so, really, even in the states that have insurance mandates, it's the implementation that's the real test for the efficacy of the mandate and whether or not it actually does increase access to IVF. And we'll take the example of California for a moment. So as we discussed above, California SB 729, it promotes IVF access, but it does showcase an implementation gap. Last July, the governor asked lawmakers to push the implementation date of the law to January 2026. And that was a second time that lawmakers were asked to delay implementation of the law. Again, it was just because it requires coordination between the state, between the payors. Further, California's law does not necessarily require IVF coverage to start until the month of the employer's renegotiated contract with the applicable state regulated payer. So even after the law has taken effect, for example, this past January, it's possible that an employer and a payer have not necessarily renegotiated the contract until months later. So again, there is a lag as to when, even under this mandate, certain patients are able to avail themselves of the availability of IVF coverage through their payer. And it, again, varies by employer and by payer. In addition, it takes time for states to issue guidance to payers as to what services must be covered, and any restrictions in coverage, restrictions, limitation, applicable criteria. And so without state guidance, insurers cannot determine exactly what to cover, and by extension, then members, patients are not necessarily, don't necessarily know what coverage they have access to. And, even within a state with an IVF access mandate or some form thereof, network and geography and network adequacy can be an additional barrier. While, metropolitan areas like LA or New York may have multiple full service fertility clinics, in some states, or some locations, there may only be a single IVF clinic or a single IVF provider. And this is a very, as all of our physician panelists here can tell you, you have to be a specialist to be able to do IVF. So there is a demand for the specialists. There may not necessarily be clinics available, and patients in rural or otherwise underserved areas may lack adequate care, despite being in a state where payers are required to provide some sort of access.
I think you bring up a really good point there, Carmen, which is that there's usually a lag time between when a law actually passes and when the patient actually receives a benefit. So I want to bring it back to Dr. Thomas. In your opinion, beyond coverage itself, what are some of the main operational constraints, such as maybe capacity or staffing, that most limit patient access to fertility care?
Yeah, so it's actually really important to look at the fertility care in three arms. We have the clinical side, the laboratory side, and then the surgery side. From the clinical side, as I touched on earlier, nursing staff is one of the constraints. So these are highly skilled nursing support staff that help with cycle management, ordering, and counseling patients. Additionally, the pharmacy constraints on that side. So ordering medications depending on the pharmacy that is dictated by the specific insurance plan can limit access to patients when they're allowed to start when those medications arrive. From the laboratory side, that's one of our biggest limitations that we see is these are highly skilled, highly specialized embryologists and andrologists that specialize in fertility care and micro manipulation of egg, sperm, and embryos. And so that is one of the primary limitations that we see in the lab is, do we have adequate staff to support as many cycles as we need to perform, and to be able to operate on essentially a 7-day-a-week basis to adequately support those cycles for the patients. And then from the surgical side, again, adequate anesthesiology to support the patients as well, and post-op recovery for those patients. So we have to look at it from three arms of, does that clinic have the right subspecialists to support them in terms of the surgeons and the reproductive endocrinologists, the highly specialized embryologists, they're limited in their capacity to perform a certain number of cycles safely, and then the nursing staff and anesthesia that's needed for the surgical arm. And so that limits patients' access to care. Does those clinics have to then resort to what we call batching, where they're limiting when they can do the cycles and their patients are limited to when they can actually undergo IVF because that clinic or those labs have limited capacity to support those cycles. So those are all things that we see how operations affect patients' ability to proceed with care in a timely manner.
Yeah.
Can I add something also in addition to all of those like excellent all of those parts of the care, you've also got your billing and your insurance specialists. And I think that one thing to tell you guys here is that it seems like every single patient, when our insurance specialists do their benefit check, comes up with a different answer on what is covered, what is not covered, how much is covered. And there's this like totally patchwork, no standardization, different for every plan because there's sort of different things that the insurers have negotiated with the employer groups. And so it's all different every single patient. And so it's like reinventing the wheel for every patient. And then the patients get so frustrated because it's very hard to get straight answers. And the insurance and billers in the office are like another layer of highly specialized, highly technically competent professionals who have to understand exactly what we're doing. And remember, I said that we're so committed to personalized care. On a clinical level, we have different things that we do for each patient. It's like impossible for an insurer to understand what it is that we're doing and then to like understand what they should be covering. And so I don't know if we're going to get into there are these third-party specialized fertility insurances that tend to have a better understanding of what it is that we're doing. They tend to have a better understanding of what is cost effective and what they should be covering and what they should not be covering. And so they do tend to be easier for us and our practices to work with than the larger insurance groups.
Thank you so much,
Thanks.
Dr. Goldstein and Dr. Thomas. What was that, Carmen? Did you have something?
No, and we'll discuss provide an overview of those third parties shortly. So thank you for flagging that for us.
Perfect. Let's move over to our next slide on federal action and its role here.
And I think, if there was federal action, I think not all, but a lot of the barriers and challenges and that patchwork aspect could potentially be at least alleviated, if not resolved. Federal action could potentially help in three major ways: reducing prescription drug costs for patients and for plans, creating a structure where those federally regulated self-funded plans could have an accepted benefit that would expand applicable state, or if there was a federal IVF mandate, to those plans. And presumably, to the extent there was such a federal mandate or federal mandate or law, applicable guardrails that would provide clarity to payors, patients, and clinicians on certain key definitions, on certain compliance rules or regulations, and applicable standards. Now, again, that doesn't mean it will resolve all of the challenges and issues, but could potentially alleviate a lot of these barriers to IVF access.
Thank you. So this conversation about federal action does bring up an important broader point about the actual day-to-day operations of the clinic, such as Beverly Hills Fertility. So let's shift over to Dr. Hackman. We discussed some of these operational realities. Which do you think are least understood by those outside the clinical setting?
It sort of kind of goes hand in hand with what Dr. Thomas previously mentioned about how everything is so specialized. We differ from other medical specialties in the sense that we have an embryology lab and there are so many processes behind the scenes that have to take place in order for patients to have successful cycles. And so the part where people don't quite understand is that protocols differ from patient to patient. While you can have some sort of standardization, a lot of it does have to be, it is nuanced and it has to be modified based on a patient's history and current presentation. And this is where you need clinical coordinators that significantly help with that process. And they require a lot of training to get there. And then all the way down to the embryology lab, where there's a limited number of cases that you could do at a certain time. And so while it is amazing how we are getting increase in mandates for insurance coverage, this is great for access to care. That access doesn't always necessarily translate in a timely manner, not only for implementation, but also because there will be a bottleneck effect. As more people can access this care, there is not necessarily more availability within clinics because Obviously, if you take somewhere like LA or New York, those are exceptions because they're extremely saturated, but there's also a lot of sort of geographical deserts, and I know we're going to get into that shortly as well, where there is a massive demand. And if you have increased financial access to care, it doesn't necessarily translate into being able to get into the clinic right away, given the fact that there are limitations to how many cases you can do in an embryology lab safely. Embryologists are very, very hard to come by. They're highly trained, highly specialized. Same with reproductive endocrinologists. So you can't just increase the staffing, increase the reproductive endocrinologists and embryologists to accommodate these increased cycle demands.
Really appreciate that, Dr. Hackman. So I think now we'll discuss some additional barriers that clinicians face from a more systemic standpoint. So let's go to the next slide.
Thanks, Aliana. And I think we've actually discussed some of these already, and I think it's great that we're having this dialogue. We've talked about the payer implementation lag. Again, payers need guidance. If there's a requirement, payers need guidance in order to have that be negotiated into their agreements. From a benefits packages if that insurance plans provides may not necessarily apply to all patients. There may be certain requirements based on what a specific benefit defines infertility as, whether it's based on a number of failed attempts at conception. There are implications as to what patients potentially just are not able to meet the definition to qualify for infertility, such that then they could then be able to access IVF. And we discussed several administrative frictions. Doctors Goldstein, Thomas, and Hackman really have. So I will, I think actually, Aliana, if you want to proceed to the next question we had for Dr. Goldstein, I think that would be informative.
Okay, perfect. So let's shift this over to Dr. Goldstein. So we've talked a little bit about prior authorization, but we wanted to kind of delve into this a little bit more. We talked about this as a significant friction point. Can you walk us through how this process actually works in the context of fertility treatment and what a typical timeline looks like from a clinical standpoint?
Sure. So when we meet patients, many of them, especially in parts of the country where they've had to wait longer for their initial consultation, they wanted to have their baby like last year. And so they're ready to go. And once we meet them, we can often get things going pretty quickly because we also care very much about getting them started pretty quickly. And age is by far the most important factor for fertility treatment success rates, especially when women get older than 37 or 38. Every 3 to 6 months of delay is a significant downtick in their chance of success with our treatment. And so prior authorization typically takes about 3 weeks from when the biller submits a comprehensive file on a patient to the insurer. We usually don't get an answer until about 3 weeks later about whether that patient's cycle is covered. And then there's also issues with medication coverage and all of that stuff. And so many patients are committed to they want to use their benefit, and so they're not going to start their treatment until we get everything all squared away, of course. But women have menstrual cycles, and our treatment is cycle day dependent, and we have to start at certain times in their cycle. Also, many of the insurers require you to jump through hoops that are cycle day dependent, that actually are antiquated and that we don't use anymore. So any of you that may have gone through fertility treatment, you may remember having labs drawn on day 3 of your cycle. This is actually not usually clinically useful information for us, and it's not usually something that we would need, but the insurers just haven't caught up, and it takes them a long time to catch up, and they require day 3 labs. Well, if I meet a patient and she's, cycle day 10, she can't get her day 3 labs drawn until cycle day 3 of, it's 20 days, usually about like 20 days later. And then she gets those labs drawn, and then we wait for the results, then we submit the file. And so now she's waited usually probably 2 months from when she met us until she can actually start her treatment cycle. Whereas if I didn't have that prior authorization barrier, I could start her pretty quickly. And it matters. Patients are really stressed out by this. And if there's and again, like I was saying, the insurance and billing specialists, it's so complicated and there are errors. It is, it's a human field. And this tends to be the most frustrating part of fertility treatment for patients.
Okay, We appreciate that perspective, Dr. Goldstein. Let's shift over to our next part, which does dive into this as well. Can we go to the next slide?
Mhm.
Perfect. So we're gonna now talk about the payer landscape, and I'm gonna hand it back to Carmen.
Sure, thanks. So we've touched on this somewhat, but basically there is an increasing demand for IVF access. There have been some studies that have, for example, by the Maven Clinic, that have suggested that it's a bit generational, that there are many more, based on these studies or reports, that many Gen Z workers are willing to switch jobs or have seriously considered job offers based on the prospective employers' fertility or family planning benefits, as compared to other, like, for example, millennial employees. And a large percentage of similar reported that approximately 46% of Gen Z workers that were surveyed were considering fertility benefits as to why they choose to stay in a company versus seeking a role elsewhere. And so employers are increasingly reporting that they believe reproductive and family health benefits are important for attracting prospective hires. So demand is increasing. That said, again, there's this nuance here where a lot of employer-based payers are not required to adhere to state IVF access mandates if there are applicable mandates. And so it's largely voluntary for those payers. And this is where collaboration and agreements and contracting with different third-party vendors, third parties that are basically take on the role of acting as the payer or plan for specifically for fertility-based services come into play. Plans can then coordinate with these vendors. Coverage differs drastically among companies. And whether or not the third party offers services such as egg harvesting or freezing or other types of fertility service, again, varies. There's different types of designs. There can be cycle-based designs, which allow customers flexibility to access fertility services without running out of coverage mid-cycle. There's other designs that are more dollar-based, which allow for employers to budget more accurately while still providing access to care. Again, all of this also in collaboration with applicable pharmacy costs, which may have lifetime benefit maximums that apply to these types of services, and those can vary by customer or by plan. And, these fertility benefit managers each then have their own authorization practices, billing rules, and network requirements. Although, to Dr. Goldstein's point, it is possible that it is easier to work with those vendors than other types of payers because they are focused solely on these types of services. Some of these fertility benefit management coverage models require clinician network participation in order for the clinicians to bill directly and get reimbursed. Others may have some sort of an out-of-network coverage. But there can be issues where, there are hiccups, let's call them, right? Continuity of care is important, especially when you think about what Dr. Goldstein described as that process that takes weeks to months for everything to align in order for the patient to be able to go from initiating an evaluation to actually having the IVF procedure, the surgery. It can be complicated if an employer switches fertility benefit vendor or a benefit manager in the interim or mid-cycle. In addition, again, some of these do not necessarily cover the egg harvesting or the freezing that has to be done at the earlier stages. And so, there are potential snags in the process where a patient is receiving services and then there's a change in the fertility benefit manager, and now the patient is no longer able to avail themselves of the access that they would have had a contract between employer and plan, or plan and fertility benefit manager not been renegotiated. And it varies. And next slide. And once again, it really depends on coverage, and consider how many people who would potentially like to avail themselves of IVF have Medicaid. Now, Medicaid is a program that is funded by both federal dollars and state dollars. And Medicaid coverage varies by state. Some states, with respect to all types of services, not just IVF, and it is up to the state to include certain services or not within its Medicaid benefits. No state Medicaid program covers IVF as a standard benefit. It is not, fertility treatment is not a mandatory Medicaid benefit under federal law, and many states choose not to cover it. If anything, the most common covered benefit under Medicaid programs is fertility preservation for those with infertility that is caused by medically necessary medical treatments, like, for example, chemotherapy. 7 states provide that kind of coverage. I believe Utah is the only state with Medicaid IVF coverage, but it only applies to individuals with certain genetic conditions. And then there's other states which, like New York and Washington, D.C., which have Medicaid plans, but they only cover up to a certain number of cycles of medications. And so really, when you think about it, Medicaid enrollees are systemically less likely to seek or be able to complete fertility treatment as compared to privately insured patients. And, you know, from a socioeconomic perspective, Medicaid patients are disproportionately persons of color and of low socioeconomic status and underrepresented minorities. So they may not necessarily have access to IVF. They may have higher rates of infertility. And the majority across the country, really, the majority of patients who are accessing fertility services tend to be highly educated and wealthy and, frankly, not on Medicaid. And so even in a state that has a mandate requiring insurers to provide some sort of IVF coverage, there are still disparities that persist along potentially racial and economic lines. And the Medicaid coverage is just one example of that. And even to the extent that Medicaid covers these types of services, they tend to be less generous than commercial payers. Next slide. And I realize we're running out of time, so I will stop.
Okay, great. So now we're just going to talk briefly. Like Carmen said, we are running short on time for the programming, but we'll discuss the restrictive definitions of infertility, and then we'll hear from Dr. Goldstein on the next slide.
I mean, well, I want to be able to hear the clinicians really. So, but again, some payers require or some states define infertility based on either a certain amount of time that attempts at conception have not occurred. Sometimes it's based on whether or not somebody has an underlying medical condition. I think this slide is pretty self-explanatory, so we can move on. Again, I think we've discussed, again, this is pretty self-explanatory. Just because there's coverage does not necessarily mean there's equal access to or equal usability, whether it's because of age, the patient's clinical condition, or any applicable limitations on coverage based on a payer. So, continue.
Okay.
I have 2 points from those last slides. I mean, one from 2 slides ago that was really interesting was talking about how, there are these exclusions and that you have to actually prove infertility. One that comes up a lot is egg freezing in endometriosis patients. Egg freezing is quite often, is usually considered to be elective treatment because, you're doing it it's even called a social egg freezing for single people who just don't have a partner yet and are freezing eggs for the future. And it is the best thing we have for young women who don't have a partner who are getting closer to age 35. And so I constantly get questions from people trying to get me to try to make the case to their insurers that they should have egg freezing covered by insurance because they have endometriosis. And I say, like, yes, you have a higher rate of infertility in the future, and this is a medically advisable thing to do, to freeze your eggs, but it's still considered elective because you don't have a partner and I can't prove that you have infertility. And so, I'm of two minds there. Like, I mean, I think also it sort of goes along with actually the next slide, which, you were saying that it was a bad thing that insurers don't cover IVF past the age of 46. Well, I would say, why would the insurance throw its money away on IVF in somebody who's 46 or older? Like, if it's not going to work, it's not going to work. And insurers do have to make financial decisions like that. So it's always going to be this very complicated conversation, that the issue is that the doctors have the expertise in discussing these things that the insurers don't really have.
Yeah, thank you for that, Dr. Goldstein. We only have a few minutes left, so let's start on slide 21, structural barriers.
Mm-hmm.
And then we'll move to Dr. Hackman for one of our final questions.
I think doctors, the physicians have addressed this, just the structural barriers. I think we can move on. I really would want to hear more from the clinicians. So if you want to move on to the next slide, that's great. Did we skip it? Oh, here we go.
I can just stay on this slide. So we're just gonna have a very short discussion on the evolution of fertility care here. We did cover a significant amount of ground on legal, legislative, and coverage issues related to fertility care. So now we'll look at fertility care itself, which includes the patient experience and the broader populations that fertility medicine now serves. So let's just actually bring it back to Dr. Hackman and talk about what the day-to-day patient experience is like for those undergoing fertility treatment, from the initial consultation through treatment cycles, and how that experience has changed over time.
So generally speaking, when a patient has an initial consultation, you basically have two types of patients. The ones who come already with an evaluation that's been completed either by their OBGYN. Some patients really take a lot of this data into their own hands. Now we have blood panels like Function Health, where they already come in with a comprehensive set of labs, and they've been tracking their cycles. They may know what's going on already, and they come with an idea of what they want for treatment, versus a patient who comes in sort of like a blank canvas, has been trying to conceive, has no idea why things are not working out. For the patient who sort of already knows the treatment regimen that they are pursuing, whether it's IUI or IVF, if we're talking about the IVF route, that's a lot more comprehensive, where patients then need a checklist of labs and imaging completed, as well as a semen analysis if there's a male partner involved. And then from there, once you schedule their cycle, that's when, they always start off with a baseline to ensure everything looks good. It's an average of about 2 weeks of ovarian stimulation, if it is what we call an autologous cycle, using their own ovaries, where they come in on average a total of 5 visits. There's a lot of constant communication that is happening in order to adjust medication dosing based on response, all the way up to the point of when the ovaries are ready for egg retrieval. They get something called a trigger shot, and 36 hours later, approximately, is when the egg retrieval takes place. That is the largest physical commitment that a patient needs to do. And since we're on the slide about ghost coverage, something I want to bring up, because I actually wrote a publication on this and did a study on this in the past. There's a lot of these patients who live in more rural areas who don't have immediate access to a local clinic that can do that monitoring. So the experience really varies based on geography, where you live. If you live somewhere like LA, you are able to drive somewhere nearby to get your ultrasound and blood work that is frequently needed. And in some cases, if the practice opens up early in the morning, you can potentially even get in and get out before you go to work. For others, they may not be able to do that. They have to take time off of work. For those who live far away, I have patients who live in Fresno and they drive, 3 to 5 hours each way just to come in for their monitoring appointments because they don't even have anyone locally that can do that for them. And so what that translates into is either making the decision to take time off work if they've run out of PTO, that's an added expense even if they have insurance coverage, plus the expense of the actual travel versus physically staying in the city where they are monitoring for the duration of those 2 weeks. So there's a lot of visits involved. After the egg retrieval, once you go to create embryos, there is a bit of a lag before you get to the embryo transfer process. And that does require a lot less visits, but the ovarian stimulation portion of treatment is probably the most demanding if we're talking about day to day. For the embryo transfer itself, when you get to that point, it's usually an average of 3 to 4 visits until the embryo transfer, depending on the medication protocol that has been selected. But usually there's also additional imaging that's involved in order to ensure the uterine cavity is appropriate for transfer.
Thank you so much, Dr. Hackman. I know we're about a minute past programming. I just want to bring your attention to, for those registered in New York, I did put the information in the chat regarding getting CLE credit for this presentation. So please click on that link. The code word to receive credit is alternative. If you have any issues accessing that, please let us know. But we really appreciate everyone's time here. Sorry that we did run a tiny bit late. We do invite you to join our next portion of this series, which we're going to hold in the next few months. So please keep an eye out for additional details there. We really appreciate your time today. And again, if you had questions, please feel free to drop them in the Q&A chat, and we will email you a separate response. But thank you so much for joining.
Thank you.
Thank you to our panelists. Thank you so much.
Thanks.
Bye.
Bye.
Thank you.